So most of what I do on a daily basis, probably 80–90% of what I do day in and day out is actually opiate withdrawal and opiate treatment. So meeting people where they are. And if I've got somebody who comes in who's opiate dependent, but they're working full time, they have a family, they just are not prepared to do a detox treatment, either with or without NAD or anything, then most of those patients, I'm just putting them on Suboxone and explaining the risks and benefits of that. I am not a lifer on Suboxone. I mean, I get patients on, I get them stabilized, I taper them off, and they do phenomenal. That's still whatever your opinion on it, it's still the standard of care for opiate treatment, right? Because again, we could talk all day about it, but those patients, they get stabilized, they get their lives in order, and as long as your prescriber knows what they're doing, you can comfortably taper off that and do really well. And I get patients down to 0.125 milligrams a day, and they can walk away from it. And so I get people off Suboxone. So that's still the standard of care, and I do a lot of Suboxone. Other options, like you mentioned, is Vivitrol. So Vivitrol is an extended release blocker. The challenge with that is getting patients detoxed enough to get onto Vivitrol. But we'll do that typically with traditional medications, like you had mentioned, gabapentin, clonidine. We'll use that new lofexidine. Hydroxyzine. There's all sorts of medicines, even some benzos, whatever we need to get people to bridge, the 5-7 day mark to get Vivitrol, we can do. We do the Sublocade injection, which is long-acting buprenorphine. There's some, risks and benefits to that. What else? And then, don't forget, we're still doing counseling. We still have an intensive outpatient program. We still have licensed therapists. We're still really wanting these people to do the work of recovery, right? These medicines, it's called medication-assisted treatment, not medication as treatment. So I don't want anyone to think that you can just give somebody NAD and they go on with their lives and they never look back, because they still have to learn some coping skills and do the work of recovery, right? So I guess that's, in a sense, what we do. And we might throw some vitamins at that and some amino acids and tune them up with some supplements, but just make sure they're in a good recovery program that resonates with them.